Thank you very much, and thank you for coming to listen to my talk today, and which follows on very nicely from the discussions we had this morning around advanced practice. So why did we start an evaluation looking at a pilot of an advanced nurse practitioner in Papworth? Well, nothing here is going to surprise anyone. The difficulty in recruiting junior doctors is not just a problem specific to Papworth, it's a problem that we face nationally. Meeting the junior doctors' educational needs and training needs, along trying to provide a service, is also a challenge for us all. Working Time Directive, which restricts junior doctors' hours, and at Papworth in particular, and it may be similar elsewhere, the specialist registrar's ward support is limited due to their commitments in theatre and critical care demands. Alongside that, we have a nursing workforce that's more junior, requiring more support for enhanced clinical decision-making. And with the nursing shortages that we're facing nationally, we need to change the skill mix in nursing establishments to deal with these nursing shortages. We want our clinically expert, experienced nurses to remain in clinical roles. So we need to provide them with some career progression within the wards to help them progress, and so also with job satisfaction. So we need to put measures in place so that we can continue to provide safe care in light of these challenges. So we started a pilot in November 2014. We had one advanced nurse practitioner, I'll come back to the word advanced later, on the cardiac surgical ward, and a part-time practitioner on the day ward. The first month was really allocated to the practitioners to familiarise themselves with the wards, procedures, and to refresh or consolidate any learning that they had. Who did we want in these roles? Well, we needed people who have an extensive experience in cardiothoracic nursing, first and foremost. Alongside that, in terms of what we were wanting these practitioners to do, they needed to have advanced clinical assessment skills and non-medical prescribing. I'm not going to go through all of these here, but the duties of the ward-based practitioner were, as we can see here, a lot around having that senior presence, senior nursing presence on ward rounds, ensuring that patients are progressed along the ICP in a timely way. A lot of work around enhanced decision-making and also sort of helping with discharge planning. So that's from prescribing medication to take home, to completing medical discharges, referring on to other centres. Very similar to the cardiology-based practitioner. Included in there, I guess, there was more requesting of investigations from chest x-rays, echoes, bloods, all of that sort of thing. So how did we evaluate the role? We looked at the number of calls to the alert team. The alert team, I'm sure like all of us, are very much concerned with looking after and the care of the deteriorating patient, but are also called to the ward for the more routine stuff as well. We looked at timeliness of blood sampling, patient satisfaction along with nursing and medical team evaluation of the role, ward round audit and feedback, and length of stay on the cardiac surgery ward. So again, looking at firstly looking at the referrals to the alert team, Mallard ward is our big post-cardiac surgery ward at Papworth, and as you can see here, the red is post-implementation of the pilot, and the calls to the alert team halved. The bit in the middle where you see PCU, that's a bay within Mallard ward, progressive care unit, and the alert team have more involvement with those patients as they're more highly dependent. So I wouldn't have expected, in fact, I expected an increase in that area. However, in total, looking at the surgical ward, including PCU, calls to the alert team did decrease significantly. Timings of blood samples, I mean, this may seem quite a small measure, but actually in terms of impact, when patients are admitted, sometimes there can be delays in them being clerked and blood tests being requested, and very often it gets later and later in the day when the pathology staff are operating more of an on-call basis. However, with the pilot, there was an increase in the number of blood samples sent to the lab between 12 and 3. This not only helped the lab staff, but also any anomalies that would show up in terms of patients having problems with cross-match samples, that sort of thing, were able to be acted upon in a timely way, reducing the need for perhaps maybe the patient's operation to being cancelled. Staff evaluation was another measure we used to evaluate the role. As you can see from here, this is the profile of people who actually helped to complete the evaluation, and that's everyone from healthcare support workers, band 5s and 6s, to the junior doctors and registrars and the consultants. And this is just the surgical staff evaluation, and the responses were very, very positive in terms of again, issues around timely discharge, improved communication, improved support for nursing and medical staff, more time for training for junior doctors. The negatives were around clarity around the role, the need for it to be a 7-day service, and there was a couple of people responded saying that they worried that the nurse's role may be devalued, though they weren't feeling that at the time. In cardiology, again, it was a broad spectrum of staff who completed the evaluation, and all respondents were very, very positive of the role. Again, around the same things: increased efficiency, friendly support, more time with the patients, and improved communication. So these are just some of the staff comments, which I think the one that stands out for me really is it's an opportunity for Papworth to catch up with the rest of the UK centres. I'm sure many of you are sitting here saying, oh, we've been doing that for 5-10 years. So that was quite powerful. Excellent mentor to junior doctors, and I think that's been really satisfying for the people who took part in the pilot, but also for the junior doctors, knowing that there's that sort of support there. Patient satisfaction. This is it's a bit difficult to understand, but the top box score is, all the positive replies, really. You couldn't get higher than 21. So there was six patients in that category, and all the rest, even these other ones, were also very positive. There was a few boxes unticked, which is why they're not all in the very top one. So very, very positive. Again, in surgery, this is just broken down. The previous one was a combined score. This is broken down, again, very positive, and the same in cardiology. And I think these are the comments from our patients in terms of how they felt being treated by a nurse practitioner. And lots there around time to communicate, clear explanations, relaxed, professional manner. They came out over and over again. Personal skills, excellent. So all of that is very reassuring for patients, as well as very knowledgeable in terms of what they're doing every day. Length of stay, this is always a difficult one to measure when the wards are mixed with other groups of patients. But on Mallard ward, we did see a reduction in the length of stay of patients post-op, but it started to come back up again towards the end of the pilot. We believe that more to be due to the fact that we had an increase in transplant activity, which is where these patients are also nursed, and they weren't part of the ANP's workload, if you get what I mean. However, since then, and the ANP who's been in post during the pilot and since, we have seen 6 beds closed on that ward without decreasing activity or anything. And I'm not saying that it's all down to the ANP, but it's a very significant factor. So in summary, referrals to the alert team from the surgical ward more than halved. The ANP offers a very organised and disciplined approach to ward rounds. And, I'm sure we're all in the same situation. The registrars and junior doctors are so rushed in the morning trying to see the surgical patients before rushing to theatres. The ANP offers that more organised approach and can come back and follow up on patients and their pathway. There was a decrease in the number of samples sent to the laboratory after 3 p.m. The role is, I think, the big thing here is positively evaluated by patients and by all grades of staff. Nursing and other staff evaluated positively, but some concerns were raised about de-skilling the workforce, and that is not something that we're aiming to do. It's actually the opposite, to empower nurses, to enhance decision-making. And the length of stay on the surgical ward decreased. So recommendations and actions, and where now? We want to implement a team of cardiothoracic advanced nurse practitioners to cover 7 days a week across cardiac surgery. And we want, because of the reduction in the workload onto the alert team, which will be only more with more practitioners, we want to see the synergies there in terms of pooling resources. And also consider a proposal in conjunction with the cardiothoracic junior medical staff rota. So the idea would be to reduce the number of juniors on there, but the ones that we may continue with, to see how their learning and experience can be enhanced in working with this team. So next steps is, as I say, introduction across all the surgical wards 7 days a week, and replace some junior doctor posts with ward-based A&Ps. I just wanted to comment on the educational attainment of these practitioners, and this is something we've discussed very much back at base, and following on from the conversations this morning. Yes, absolutely, the idea is anyone going into these kind of posts would have to have an MSc or be working towards it. I think we have to be realistic that, a lot of our experienced nurses don't have an MSc. However, we do expect them to be working towards that level of academic achievement. Thank you for listening, and I'm happy to take any questions.